Laboratory studies, people ask me what to get in these patients. Can you not get any labs at all? You can, as a pediatrician, as a first cut, you can just diagnose them empirically with constipation and treat. Once they make it over the hurdle of your office and they make it to my office, I almost always get blood work. There has to be some value added. They always feel very disappointed if I have just diagnosed them with the same constipation that you did. So this is part of the smoke that I have to provide in the office. I have to do the value add. Rufo did lab testing. It was really very thorough. And I, of course, reinforce, yes, it is very thorough. We will be very thorough. So we get blood work. CBCs and differentials. Is there an eosinophilia? Are they anemic? Is this a person with a hypercalcemia, which can predispose people to constipation? You just gotta screen for celiac disease. 1% of the population has celiac disease. Only 25% of Americans know they have celiac disease. Almost nobody goes because either they don't recognize the symptoms or they don't want to be diagnosed with something that tells them they can't eat pizza. Thyroid function testing, lead, which you just have to go in a case-by-case manner. I used to get lead on everybody. I trained in Baltimore. There was lead everywhere there. In Boston, there's no lead. I just stopped looking for it. But if you live in the inner city or a redone house, something to look at. I'm also a pretty big fan at some point of getting a KUB. Remember, these parents don't know necessarily that their kids have constipation, and they often benefit when they see a KUB full of stool. You can get markers of inflammation, either occult blood, lactoferrin, or calprotectin. These are things that point us more in the direction of an inflammatory process. There are some second-tier tests to get that I typically don't recommend pediatricians order, that I sometimes will get if you have sufficient concern about what you saw anatomically or functionally when you tapped on the arms and legs or looked for an anal wink. I might get an MRI. I might refer for anorectal manometry, once again, formally test the ability of the muscles and the nerves and the perineum to work together. Or you can do transit studies, which are also can be useful if you want to figure out where stool is getting held up. Spina bifida occulta, you'll see on a KUB. This may or may not have clinical relevance, but when you get your KUB to look for fecal load, always see if you can look at the spine and see whether or not there's any evidence of dysraphism. Obviously, if this gets bigger and bigger and bigger and bigger, you have to be more concerned. And if it gets big enough, then you have not spina bifida occulta, but spina bifida for real. Other organic causes of constipation and perforate anus, that should be evident if you look at the bottom, although people don't often look at the bottom, but it's always important to do so. We talked about anterior displacement or anal stenosis, which you'll diagnose on a rectal exam. Metabolic causes, you'll pick up on the Chem7, hypocalcemia, hypothyroidism, hypokalemia, diabetes, more in older patients, cystic fibrosis, lead, and vitamin D toxicity can make people constipated, although it's vanishingly rare, and you're much more likely to deal with kids who are vitamin D deficient. Non-organic causes are myriad, and I think that Dr. Estrada mentioned a lot of them. Probably the one that I'd talk about here is pseudoobstruction, patients who have functional causes of functional or mechanical causes, functional obstruction in the absence of a mechanical cause. Basically, the nerves are not working with the muscles, or the muscles are not working with the nerves. And these people present with abdominal distension, pain, constipation, and the like. They can have megacystis, the same pathology that exists in the rectum and in the colon can happen in the bladder. They might have very complex comorbidities, and management of these people is tertiary and usually done at centers and even by people who are more specialized than myself. Functional constipation is what we all deal with, what you deal with in the office, what I deal with in my office. Where does it come from? In infants, dysfunctional potty training often rears its ugly head. Parents want their kids to train at a particular age because they have to go to preschool or a particular preschool. You can't really make a kid train any sooner than they want to. It's a developmental process. There's a myelinating process that goes with cortical control. You just can't make a 18-month-old potty train, although some parents will. If you push, they get anxious, the kids withhold, toileting becomes threatening. Great for business from my point of view, but very unfortunate for the kids. School-age kids, constipation almost always caused by interrupted function, illness or injury. They get backed up and they get really constipated, or bathroom availability. Kids don't use the bathroom at school. They will not. Don't ask them to. Don't include that in your management plan. They will not go. Stop fighting that battle. Don't encourage them to. You can give them a note, and sometimes they'll use the note in the nurse's office, but not always. But the presence of school, this is one of those big things that happens in the fall, why their constipation gets worse, because they don't use the bathroom at school, and who can blame them? And you end up with the cycle that painful defecation, fear of defecation, withholding, larger stools, more painful stools, and an ignominious cycle.